All right, good morning, everyone. Thank you for attending our symposium today. My name is Irma Hashmi, and I will be presenting on pelvic floor disorders with a focus on chronic constipation in the female patient. I have no financial disclosures. So before I dive into my presentation, I'd like to begin with a word on the term pelvic floor disorders. Pelvic floor disorders occur when the pelvic muscles are weakened or injured, resulting in symptoms such as urinary difficulty, bladder prolapse as indicated in my image here, urinary incontinence, vaginal prolapse, fecal incontinence, or chronic constipation. But of course, the topic of today will be to focus on the GI pelvic floor disorders. So what are our objectives for today? I'd like to begin by identifying the etiologies of chronic constipation. I'd like for us to be able to describe the evaluation of defecatory disorders. And I'd like for us to identify the role of interdisciplinary management of defecatory disorders. Okay, so before we talk about the etiologies of chronic constipation, let's take a moment to appreciate some of the background on this disease state. Constipation is fairly common, as I'm sure many of you have seen in your clinics, primary care, GI settings, and it affects about 15% of adults with, not surprisingly perhaps, a female predominance. There's a female to male ratio of about 1.5 to 1. Constipation can be defined when a patient notes that he or she has bowel movements less than 3 times per week, incomplete evacuation or straining, and if he or she notes digital assistance is required for defecation. But why does constipation occur? If you were to study the pathophysiology, it's quite easy to understand if we base it on anatomy. So we know that we know that the purpose of the right colon, the ascending colon, is to store and mix contents. The purpose, it's not working. Okay. The purpose of the left colon is to store contents, and the purpose of the rectum and the anus is to hold stool and to allow for proper defecation. Now, constipation develops when this activity is affected. Thank you. Due to imbalances or disturbances in colonic motor dysfunction as well as pelvic floor dysfunction. Sorry, is this working? Oh, the laser, yes, thank you. That's okay. I don't see the mouse. Oh, here we go.
It's kind of.
Yeah, okay.
To use the mouse, you'd have to.
Say that again. Okay.
You have to move the mouse this way.
Understood. That's helpful. Thank you so much. Okay, so let's talk about the criteria of chronic constipation that exist within the GI world. We have two broad categories. I'll speak about the AGA criteria first, which relies on symptoms, anorectal tests, and colonic transit as its way of categorizing chronic constipation. They define it, or they delineate normal transit constipation. That is to say, patients have transit of stool at a normal rate, but patients still cannot evacuate their bowels. They also delineate slow transit constipation, meaning patients have reduced ability to have constipation, and they also do comment on defecatory disorders, which we will talk about momentarily. We may, however, be more familiar with the Rome 4 criteria of etiologies of chronic constipation. And the Rome 4 criteria essentially differentiates functional constipation from chronic, from IBS, constipation predominant type, and they also address defecatory disorders. Important to recognize is that IBS constipation has a pain predominant symptom. Now, while I have discussed the primary etiologies of chronic constipation, I don't want to forget about talking about secondary etiologies of chronic constipation. And this is extremely important to recognize, especially when we're meeting our patient in clinic and trying to understand why somebody may have chronic constipation. So systemic diseases such as hypothyroidism, type 2 diabetes, hypercalcemia should certainly be considered, as well as medications. Of course, we're all very familiar, opioids do cause constipation, but do we remember that also NSAIDs, antipsychotics, diuretics, and antihistamines are very strong causes of secondary constipation? So we've described there are different types of constipation. That's great. But how do we figure out what type our patient has? And especially, how do we evaluate for defecatory disorders? Dr. Lacey has an excellent figure in one of his publications in which he actually helps us walk through how do we evaluate a patient with chronic constipation. So let's do that. So of course we begin with our basics. We always want to make sure labs and history and physical is performed in our initial clinic visit. And then we want to go ahead and trial some fiber and some laxatives. And of course, we know we're great at doing this, and hopefully our patient is going to do really, really well. But unfortunately, what happens if our patient doesn't do well? Interestingly, he actually introduces the concept of anorectal manometry quite early on in his algorithm. And we'll assume for a moment that anorectal manometry, which I will discuss momentarily, but let's assume it's normal. What happens? At this point, then, we can start to figure out, okay, does my patient have normal transit constipation, slow transit? And you can assess for colonic transit what's a surrogate marker, such as a SITS marker study. But let's assume that our patient does not have a normal anorectal manometry study. Let's assume that's an actual and abnormal finding. I want to draw your attention to the right side of this figure. And I want us to start to begin to think about, maybe our patient might have a defecatory disorder. And so Dr. Lacey then goes on to say that further evaluation should be with a defecography study and even consideration of surgical intervention if we were to find other comorbidities such as rectal prolapse or rectocele. Okay. So I've alluded to the term defecatory disorders a bit in my talk so far, but I'd like to now introduce you to the formal definition of defecatory disorders. So these are disorders that are caused by reduced rectal propulsive forces and or increased resistance to evacuation. And this is a lot of abstract words, so what does this actually mean? Well, believe it or not, an anorectal manometry is a great way to help understand this concept. And while it seems a little complicated, it's actually not. I just want to orient you first to this graph. We have, again, similar to an esophageal manometry, a heatgram. And on the x-axis, we have pressures. Again, lower pressures are delineated with cooler colors like blue and green. Higher pressures are represented with darker, warmer colors such as red and this deep purple. And on the y-axis of anorectal manometry, we have anatomic orientation. So we have the anus represented on the lower half of the graph, the rectum represented on the top part of the graph. And what we can appreciate here is that at rest, our body has some anal tone. This makes sense. We can also appreciate that when a patient is asked to squeeze the anal sphincter, we have an increase in pressure. This also makes sense. It is in evacuation where we have a really interesting phenomenon where rectal pressures must increase and anal pressures must decrease to allow for successful defecation. In defecatory disorders, this is actually affected. How so? Well, you can have paradoxical contraction. That means that, the rectum is doing its job. It's creating propulsive forces for stool to move distally, but instead of relaxation, there is an increase in anal pressures. We can also have a defecatory disorder such that there are decreased propulsive forces. This means that the pressures within the rectum are not sufficient, even though the anal pressures might be appropriate and relaxed and allowing for defecation to occur. Or we could have a combination. We could have, we could have decreased propulsion and at the same time an increase in anal sphincter pressures. Okay, so I walked you through history physical, I walked you through an algorithm, I walked you through anorectal manometry, but how do we actually apply this in real life? Well, I want to introduce you to my patient. This is not actually her. This is a stock image. But she does represent a very lovely 73-year-old female who came to me about a year ago. And she had said that she had had chronic constipation for many years, for 20 years or so, forever, doc. And during the history, I was able to say that, or to elicit that she did have 5 to 6 bowel movements per week. She had a Bristol score of 4 or 5. She noted significant straining. She also agreed that she did have incomplete evacuation, daily fecal smearing, no abdominal pain, and she used digital manipulation to help with defecation. She had tried Miralax in the past with some success. And so here, I'd actually like to pause for a second and really highlight teaching point number 1, which is how important it is to do a thorough history when meeting the patient with chronic constipation. Please do ask not simply for the number of bowel movements per week or the Bristol score, but also if a patient has incomplete evacuation, certainly if they have fecal smearing, how important this is, and if they've tried digital maneuvers such as digital manipulation or vaginal splinting. I'd like to focus also on the importance of fecal smearing. There are several scoring systems that actually exist, and certainly anyone can adopt these and include them into your template. And the reason why this is important is because you really want to appreciate how fecal smearing impacts your patient that's sitting before you. You want to know how frequently it occurs, if it's to stool, to gas, liquid, solid, if you use a pad or not, if it impacts their daily life, and how frequently this might be occurring. Okay. So as I continued on with appreciating my patient's case, I realized, or was able to deduce, she has normal serology, including, importantly, a normal TSH, normal A1C. Her medications did not identify any culprit medications, such as the opioids that we had talked about. And there was no pertinent surgical history. And importantly, she had a normal colonoscopy a few years ago with successful bowel cleanout. Now, the next part of the exam for me in clinic was the rectal exam, and which I performed with a chaperone, of course. Why is a rectal exam important, and how do we do it? Well, Dr. Satish Rao actually has very many videos, excellent videos online, which I encourage you to watch, excellent papers online where he really stresses the importance of a rectal exam. So this is teaching point number 2 in this case. How do we do it? For the sake of time, I'm going to highlight some of his salient features. Salient features include doing an adequate inspection. In this picture, we are highlighting perianal skin tags. However, of course, you want to make sure you're looking for any fissures, any tears, fistulas, perianal abscesses. We move thereafter to the anocutaneous reflex. This is to help us appreciate the integrity of the sacral nerves. This would be particularly important if you had an elderly coming from an institutionalized facility. Maybe the patient's on a wheelchair, may have sacral spinal defects. And then finally, palpation. And I'm going to spend a minute here really trying to help us appreciate what that means. So we insert a glove finger through the anus, and we're appreciating not only for internal hemorrhoids, for instance, and of course a rectal mass, but also we're really trying to appreciate the mucosa, the surrounding bone structures. And on asking the patient to bear down, we're trying to appreciate push and perineal descent. Now, interestingly, my patient actually had a weak push, and that was my tip-off to perhaps she may actually have a defecatory disorder. How can I say that with such confidence that, a simple physical exam can actually lead to something bigger? And the answer is because a rectal exam has an 87% sensitivity for capturing defecatory disorders and a 75% sensitivity. So it's an excellent test. So if I go back to the algorithm that I originally introduced to you guys, my patient here, I'm worried about defecatory disorder. And so, of course, the next thing I do is I ordered a defecography test for her. A defecography test is an excellent MRI study in which a patient has barium paste inserted into the rectum so that we can, in the radiology suite, and that patient then is asked to defecate, to simulate defecation. in real time. So it's a very dynamic study. And the reason why it's such a great study is because not only does it help us to appreciate how the rectum works, but we see in coordination how other organs within the pelvic basin may react to Valsalva maneuvers. We're also able to appreciate other pathologies such as bladder prolapse, uterine prolapse, as well as even rectal intussusception. Now, in the case of my patient, we were able to identify bladder prolapse in her case, uterine prolapse, rectal prolapse, and rectal intussusception. So a very complex case for something that would appear rather simple in clinic. And here I just want to really emphasize how important it is to dig deeper. Our patient had chronic constipation, but after a thorough history and a physical, we're able to delineate that she actually has pelvic floor disorders of all 3 organ systems. So what do we do to help her? Well, I referred her to my very excellent colleagues, Dr. Razak, who we just heard from, and also Dr. Masoga from urogynecology. And together did a combined robotic surgery which addressed her pelvic floor pathologies, including her prolapses and her rectal intussusception. Now, I'm very pleased to say I was able to chat with her in clinic this week, and she's doing very well. Her chronic constipation has improved dramatically. Her fecal incontinence has also improved, and she works closely with our pelvic floor physical therapist to help her get to absolutely normal. So we're almost there. Okay, so what do I want you guys to take home with today? Please remember that when you have your chronic constipation patient, do a thorough physical exam, including a rectal exam. And should there be concern for any abnormality, follow that up with adjunct testing, such as our anorectal manometry, but also MR defecography. And should there be pathology, especially multi-organ pathology, please feel free to send them our way anytime. Thank you.
Thank you.